Right. So good evening. Welcome to our penultimate MEX training event for this year. We have Miss Richardson doing a teaching session for us. And obviously you all, I'm sure, are familiar with Miss Richardson. She is one of our consultant ophthalmologists in South East London, mainly based at Queen Mary's Hospital, and is one of our gurus for all things retina, medical retina and diabetes, to be fair. She's going to be doing our talk today on intravitreal injections and maculopathy, so an interesting talk. If I can get everybody to keep their mics on mute. However, if you do have questions, there'll be an opportunity for a Q&A session after Miss Richardson has finished her speech. And over to you, Miss Richardson. Just going to
Not
share
seeing.
your slide.
Yeah. Okay, well, hello to everybody. And I'm sure you're aware that intravitreal injections have, since 2008, when they were first came into usual practice, have just mushroomed and mushroomed and mushroomed, and medical retina has gone from being busy to being crazy. This is just a talk on intravitreal injections, the indications thereof, what they do, and what we would like in referrals, please. So if we go on to the next slide. So what do we use them for? The one of the big indications is wet macular degeneration, and it's made a huge difference to wet macular degeneration. However, we are limited by what NICE allows us to treat. And so if you have a patient whose visual acuity is count fingers, we can't treat that patient. Their vision is too low for treatment. It has to be above 3/60. So don't promise somebody with very poor vision that they can have treatment, because they can't. Our hands are tied. NICE is reasonably strict about it. So they stipulate vision of above 360. Please, 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 please send OCT and color images if you've done them. It helps us, because then we can triage. If the vision's below 3/60, as I mentioned, don't tell the patients they'll be seen urgently. They won't. Don't tell them they'll be treated. They won't. They are beyond treatment. It won't help, and we can't treat them. And disciform scars shouldn't be referred. The only exception would be if you see a humongous hemorrhage obscuring the macula, because then we would treat them urgently. We have various trials going on at Denmark Hill. Also, just a quick note, drusen cause distortion. Distortion does not equal wet AMD. So just because they've got distortion doesn't mean they have wet AMD. So can we go to the next slide, please, Bavina? So these are all my patients. These are all people in the last couple of weeks. This is a gentleman who presented with this in his macula. And this is, as I say, this has got the holy trinity of signs for wet macular degeneration. You've got an enormous pigment epithelial detachment. You've got subretinal fluid there on the left, and a couple of little intraretinal cysts towards the top. So he was immediately treated with faricimab that day. So going on to the next slide, please. So, oh, we've hopped one, I think. Yeah, so another big indication, DMO, diabetic macular edema. So just from your point of view, the protocol for South East London, and this was agreed between Sam Mann and myself. We did a lot of work, particularly during COVID, when we weren't seeing quite so many patients, to work out pathways for South East London. And the pathway for diabetic patients is that they should be referred to diabetic screening, not to the hospitals, unless you have significant findings. By significant findings, I'd mean new vessels or significant diabetic macular edema. And I'm going to come on to tell you what that is. Please don't call this CMO. It's not cystoid macular edema. Macular cysts and cystoid macular edema are two different things. So here we go. This is DMO. So if there is mild cystic swelling, so if you've got a few cysts in the macula and the vision 6/6, there is good evidence that observation is the best management. Referral is, that's not an easy one. Can we go back to the previous slide? Referral is not urgent. If you've got a few little cysts, visual acuity 6.5, you shouldn't be referring urgently. That should go to diabetic screening. Treatment with intravitreals can commence, again, this is a nice guideline, when the central retinal thickness is 400 microns or more in the central or paracentral fields. So, you know, if you've got if you on your OCTs have a central retinal thickness of 318, we won't be able to treat that with injections. So just bear that in mind. The other thing to really bear in mind, because I know you will be referring it in with cataracts as well, is the very, very important feature of the cataract surgery and timing with diabetes. If you take a patient with diabetic macular edema and you do cataract surgery, it will worsen. It will definitely worsen. And you should ideally treat the diabetic macular edema before you operate. Those patients need careful counselling. And it is the bane of our medical retinal lives at the moment that we get patients who've been operated on elsewhere, who are then, who they rip the cataracts out and throw them at us and say, oh dear, the macula's terrible. Well, you know, you do need to plan. And it's unfair on the patients as well, because their vision doesn't improve and they're scared and disappointed and upset. So if a patient has significant diabetic macular edema, they should be coming to medical retina for management before you even think about cataracts. Exactly the same, really, when you're thinking about wet macular degeneration and cataracts. Leave it to us. We will time the surgery, because if you operate on somebody with wet macular degeneration, you will make their macula worse. It's the very fine balance between the of the blood retinal barriers. They will get worse. So we need to time that very carefully. So if somebody has significant diabetic macular edema and cataract, refer them for the diabetic macula, and then we will deal with the cataract when it's safe and appropriate to do so. So if we could do the next slide, please, Bhavina. This is a diabetic with significant diabetic macular edema, and that sort of funny appearance there, which does look like subretinal fluid, but it's just really the retina is just so swollen and elevated that it's pulling the retina upwards. But there, so that's DMO. Again, big cysts. Moving onwards, please. So vein occlusion, we can again use the intravitreals for vein occlusion. Again, our uses would be in macular edema, again, only significant macular edema. And again, you know, if the visual acuity is perception of light, we're not going to get much out of it. Rubiosis, we do use the intravitreals for patients with bad rubiosis. The glaucoma team like us to stick some intravitreal. In fact, they sometimes do it. Put the intravitreals in, because the intravitreal will diffuse forward. It's an anti-VEGF, and it will help with, it's really to try to prevent the angle vascularizing, because once you've got a vascularized angle, it will zip up, and then you're into neovascular glaucoma. So those would be the indications in vein occlusion. Next slide, please. And this is you can see from just looking at the picture of the OCT that this is a vein occlusion. And again, big cysts in the central macula, that's probably a CRT of about 550 or something, so well into treatment. Next slide, please. So what are our options? What drugs do we have that we can use? So the new kid on the block is faricimab, which is called Vabysmo. It's the newest. It's licensed for wet AMD and for DMO, and it's just been approved for retinal vein occlusion. Of course, naturally, it's the most expensive. But it's dual action. It blocks two growth factors. It blocks VEGF and it blocks angiopoietin 2. So it is reported to be more effective, particularly for wet AMD. And in South East London, we're using it for new wet AMDs, for wet AMD patients who are becoming what we would call injection junkies. So they're people who are requiring very frequent injections. The advantages of Fari is that you can extend the period between injections, and ideally you can get people up to 16 weeks, which makes a huge difference to the patients and obviously to our clinics. The second most common used one would be aflibercept Eylea. which we use. We use it for wet AMDs. Many patients are stable on it. We use it for vein occlusions and for DMO. It blocks all isoforms of VEGF, and it's a good drug. But probably we would start people on Fari for novel wet AMD at the moment. If somebody's not responding to Eylea, we'd swap them to Fari. Ranibizumab, which is licensed as for exactly the same for Eylea. It's what it used to be called Lucentis. It's cut off patent now, so it's been called various different things. And it has a shorter period of action. That's why it's really gone out of fashion, because it's a 4-week interval, whereas Eylea is 8-week when it's stable, and whereas ranibizumab is 4-week. And then Avastin, bevacizumab, is the parent compound of Lucentis. It's non-inferior in the Cat and Ivan studies. The Novartis didn't want you to know that, but it isn't. But it's not licensed for use. We do use it off-label, and the VR surgeons use it when you've got somebody who's got a very vascularized retina, and you're wanting to do a vitrectomy. If you put this in a week before surgery, it shrinks the blood vessels and you get much less bleeding during surgery. It's much cheaper. Bevacizumab is about 50 quid a shot. Aflibercept is £850 a shot. That's one injection. Can we move on? So the regimens, all the drugs need loading courses separated by 4 weekly intervals. So Eylea is for diabetes, it's 5. For wet AMD, it's 3. Fari is 4 for everything. And then you go on to, for retinal vein occlusions, you go on to a PRN, so you're just controlling the edema, seeing how it responds. For diabetes and wet AMD, we use the treat and extend protocol. So you're really tailoring the interval. So you see the patient and you say, is the retina flat? If it's flat, you inject and extend the interval by 2 weeks. If it's not flat, you inject and reduce the interval by 2 weeks. You can't go under 4 weeks. The interval has to be 4 weeks or above. But as you can see, it's a huge commitment for patients. This is going on forever, basically. And it's an enormous commitment for us. We have hundreds and hundreds of these patients, and it's an enormous commitment. So can we go to the next slide? Just so that you'll be aware, because patients do come and see you just like they come and see us. After the injection, eyes feel gritty after the injection. Usually that's the effect of the iodine that we put in at the time. Iodine is bactericidal, so we want to put it in because it's the most effective treatment to prevent endophthalmitis, which is the big worry. You get a pressure spike. Obviously, you're sticking a needle with something in it into a closed system, so you can get the pressure can go up to 50. And we will know that because when we inject, the immediate thing you do is, can you see my hand? And if you can't, you take the pressure, and we would immediately do a paracentesis there and then on the slit lamp. Obviously, that would just be for the hospital. We don't expect you to do a paracentesis. So that's an immediate treatment in the hospital. Needle stick injuries to lenses, cataracts. If you stick needles into people's eyes, sometimes you may hit the lens. If we do that, you can often see it because you can see a needle track into the lens. And when we do that, if we see that, obviously we explain to the patients, but we would ask the VR team to do the surgery because the capsule will most likely tear during surgery. And if the lens goes backwards, they can retrieve it immediately. If you allow the macula to bounce fluid down, fluid down, fluid down, as we used to with the PRN treatment, which is what we'd started off, what we found was that you get a sequential macular atrophy. So that's why we try to keep the macula flat and prevent it from recurring. Retinal detachment is very rare. Touch wood, I'm clinging happily to the desk. I haven't actually seen one after injection, but the big worry is endophthalmitis. It's about a rate of 1 in 2,000. South East London, we're very good, and I can cling to the desk. But any patient with pain or redness after injection is an emergency. They have got to come immediately. We would treat them with intravitreal antibiotics immediately. And, you know, they can do anything from very well to very badly, depending on the bug. Next slide, please. Yet cautions, if you're talking about injection treatment with people, there is some very small linkage between stroke and heart attack and the use of intravitreals. Now, it's difficult because the population of people who are having intravitreals tend to be elderly people, and elderly people have strokes and heart attacks. So we say that the risk is very small, but if somebody comes in and says, oh, and you say you've sent me somebody with diabetic macular edema and they have had a heart attack 3 weeks ago, I won't inject them for 3 months because we don't want to provoke them into another heart attack. Pregnancy, and I know, you know, you may be raising your eyebrows and saying, good Lord, none of your patients are pregnant, but we see diabetics and young diabetics do get pregnant. You have to be very careful. If you see a woman under the age of about 55, you need to ask them if you're starting treatment with anti-VEGFs, if they could be pregnant, because obviously this is an anti-growth factor, and it can have an effect on the baby. So you would try to avoid anti-VEGFs in pregnant women. And I put care in advanced glaucoma. If you have, you know, those very critical discs, those big discs with, you know, cut 0.95, you really, really would want to pre-treat with iopidine and be very careful, because, you know, there is a risk of field snuff, and that you just have to be careful and to counsel the patients carefully. Next slide, please. So how can you guys help? Well, enormously. You can help enormously. You can refer wisely. Please refer wisely, because I think Mo Abu Bakr talked to you about glaucoma, and when he did, he probably said to you, every time we get a referral that we don't need to see, blocks a slot for somebody we do need to see. So if you send me 5 poor referrals, that means 5 people who desperately need to be seen can't be seen, because our clinics can't just expand endlessly. Please take a history and please give us all the relevant information. We need to know, is this patient a diabetic? Is this patient hypertensive? You know, the age of the patient, obviously. Has the patient had previous treatment? Has the patient had surgery at somewhere else? Because if so, it's their problem. Is the patient the right age? Don't laugh. I've had an 11-year-old referred with wet AMD. So, you know, think about the age of the patient, and is the patient the right age? Are there co-pathologies? Wet AMD in a diabetic, has there been recent surgery? We need to know if there's been recent surgery. We will find out because we'll ask the patient. And also, you know, if there's a new wound and a cataract and a new intraocular lens, we'll spot it. Please send us the images. We may reject the referral if you don't. If you say, you know, oh, I did the OCT and there's no images, we will reject it and say, please supply us with the images, because it allows us to triage accurately. Please don't promise treatment, because there are patients, if their vision is count fingers, we can't treat them. So please don't promise that. And please don't tell them when they'll be seen. We will see those patients. You know, we're very well aware of how soon and quick we need to see patients. The wet AMDs are the most critical, and we will get them in. So please don't tell the patient we're going to see them that day, because we won't. And please, please don't send walk-ins to RAU or CRESS, because we don't take walk-ins. It's all by email referral. So next slide, please. So just now to come on to cystoid macular edema, because I think some of the optometrists are a bit confused about this, and they're calling everything cystoid macular edema. We would not use this term for any condition with macular cysts. If you look at the previous pictures, you could see that there were cysts in all of those maculars, but none of them had cystoid macular edema. CMO is a post-inflammatory reaction. So you see it with uveitis and you see it post-surgery. And CMO is treated with topical steroids and non-steroidals, not by injections. In uveitis, if you get persistent CMO, sometimes they treat that with orbital floor steroids, but obviously that would go to uveitis. There is no NICE approval for the use of anti-VEGF in post-cataract CMO. If you treat this promptly, it will settle. And that is the responsibility of the surgeon who operated on them. So if you see somebody from an independent treatment centre who has CMO, they go straight back to the independent treatment centre for them to treat the CMO. It does respond very nicely if you treat it quickly. Please refer to the relevant unit. We don't take it terribly kindly if you send us Spa Medica's CMOs. We will just reject them and send them back. Next slide, please. So this is a patient of mine who's got CMO. Not too bad, actually, and hopefully when I see her on Thursday, that will have gone away. Fingers crossed. So next one, please. So the message is, wet AMD, look for the Holy Trinity, PED, subretinal fluid, and intraretinal cysts. Please, this is a real worry. Subretinal fluid in anyone over 60 is wet AMD till proven otherwise. Don't call it a CSR. I'm very wary if somebody says CSR in a 70-year-old. That is wet AMD. Drusen cause distortion and not an indication for referral. DMO, cystic swelling, refer to diabetic screening first, please, unless the central retinal thickness is over 400. Just a few things just to point out, which I keep getting referred on ERS and I keep rejecting. Retinal holes are not medical retina. Please refer to VR. Swollen discs are not medical retina. Refer to neuro. And epiretinal membranes are not medical retina. If the vision is 6/9 or above or better, please keep them in the community. And if you're referring, refer to VR. Just a final thing about pigmented lesions. We will only see the elevated suspicious ones. The flat nevi, please keep in the community. If you're suspicious, they are to be referred to RAU or CRESS or St Thomas's Eye Casualty. Please don't refer them on ERS. We had one recently referred routinely with an appointment in December, and I've triaged it. We've seen it in casualty and referred to Moorfields Oncology. That's dangerous. So please, pigmented lesions, if you're suspicious, you think it's elevated, or if there's subretinal fluid over the top of it, then please refer by the emergency pathways. Thank you very much.
Right, thank you very much, Miss Robinson. Does anyone else have any questions that we wanted to ask? Feel free to unmute yourself and ask, or you can type it in the chat if you like. No. You might have escaped the questions. I have one, though, I have to say. We always hear this phrase of non-inferior when we're talking about certain landmark trials. Can I get you to just kind of explain what you mean by non-inferior? That means it's better?
It means it's the same. So you know, for example, in you know, Novartis, who used to market Lucentis when it was before it went off label, they were very keen on saying that it was superior to Avastin, and the CAP trial and the IVAN trial, one of which was in this country and one of which was in the US, clearly proved that Avastin was non-inferior. So Avastin works the same. I mean, it doesn't surprise you, because I mean, basically, if you think of me with my arms out, Avastin is my Lucentis is just the left arm of Avastin. So it doesn't surprise me that they would both work. they were very, very, very keen, very, very keen to tell the patients that Lucentis was a better drug, which was a bit naughty because it's preying on people who are desperate. So non-inferior just means the same.
Yes. There are two questions in the chat, if you don't mind. One was, oh, there's more coming. I've lost it. One was, what is the tapering regime that you'd expect for steroids in CMO?
Slow is the summary. If you see if you see somebody with CMO, they need more than steroids. They need to have a non-steroidal. So if they're a diabetic, I would use Nevenac because although it's very expensive, it's better. It works better. If they're non-diabetic, I would use Acular. And I would probably give either the Nevenac or the Acular for 8 weeks. And the steroids, I would say 4 times a day for 2 weeks, 3 times a day for 2 weeks, twice a day for 2 weeks, once a day for 2 weeks. Slow. If you bring them off quickly, it'll bounce back. You've got to treat it slowly. And beware that if we're not talking about a diabetic patient or somebody with a vulnerable macula at the moment, but if you've had CMO with your first eye, you're very likely to get it with a second eye. So sometimes, for example, if I've had somebody with CMO, Mrs. Average, not a diabetic, I will pre-treat them. So I'll give them Nevenac or Acular for 2 weeks before I operate on them. So this is what I mean about the planning of surgery. There is nothing more maddening for a retinal consultant than having some patient dumped on them who has got terrible macular edema after having had surgery, because beforehand you're going to make it a much more stable situation. And the patients are so disappointed as well. It's so miserable for them.
Yeah, they're expecting better vision and
they're expecting better vision, and they can't understand why their macula's got worse. And I've had a man in tears in casualty about it because he wasn't counselled at all. Nobody gave him any time. He couldn't understand why his vision was worse, and he was crying. And this is a 55-year-old man crying in eye casualty because nobody had given him the time to just explain.
There's a few more. Do you mind if I just quickly?
No, ask away.
Thank you. It says, what if the patient doesn't know where their diabetic screening was done? How do they find out that information?
If it's Southeast London, it'll be GSTT. So you just refer to diabetic screening, and I think you've got that contact number, haven't you, Bavina? Which is if they live in any SE postcode or around Sidcup in the DA postcodes, they will be going. Bexley, Bromley, Greenwich, Southwark, Lambeth, all of them will go to the diabetic screening based at GSTT. So you have an email and you just email them. They're very helpful. That's what they do best. And they will see and advise. They may say to you, yeah, we know they've got a bit of macular edema. Don't worry about it. We're looking after them.
Yeah.
So they're the first port of call.
Yeah. So anyone who wants to know, that information is on our contact list that went round to all MEX practices. If you don't have that, then please do email the admin team, the MEX admin team, and we can send it round to you. Another question was asked about, do other hospitals treat large hemorrhaging in wet AMD with poor vision? The guidance on vision is really based on NICE accreditation, isn't it?
Yeah, there is. No, we do have a trial at King's, and I don't actually know if St Thomas's are doing it, but we have and I'm talking big subretinal hemorrhages, right based straight in the macula in a wet AMD patient. We would see them urgently, and then I would contact Prof Jackson at Denmark Hill, and he takes it from there. He sees the patient, he explains to the patient about the trial, the early evacuation of hemorrhage. It's a trial called Tiger, and we feed into Tiger if it's appropriate. So those sorts of patients, if you see somebody with a macula with a big hemorrhage, I mean, you can't miss it, then obviously they would come to eye casualty, and we would deal with them appropriately. But if
Okay.
you send us the pictures, we'll spot them quickly.
Next point. Sorry, I'm looking away from you because I'm reading the message.
That's fine.
Had a patient who was seen at Dex. They had DMO, and Dex referred them to a MEX, and the MEX practitioner was a bit confused.
He and me both.
Yeah.
don't quite know why they did that. I would say, I mean, diabetic screening aren't shy to refer to the hospital. You know, we have a lot of
Yes.
patients coming through from diabetic screening. So, you know, if they think that the patient has clinically significant macular edema, they
Mhm.
will refer to us to treat. So I have no idea why they sent them to a MEX optometrist, because it's not fair.
Yeah, agreed. Question on a medication, and it's an opinion, really. An opinion on, I can't say this medicine, so you might be able to look it in the chat. Pegcetacoplan.
Oh yeah, the
Completely
treatment
wrong.
for dry AMD.
Yes.
Yeah, no,
When, if,
no,
do you think NICE will approve?
doubt it.
Yeah, there's not
It,
enough evidence,
it's
really.
eye-wateringly expensive.
Hmm.
There's not clear benefit,
Hmm.
and there are also some quite significant risks associated. So the general feeling in most med ret people is that this is not going to get off the blocks, I'm afraid. It's unlikely to be much, you know, would be great, but I don't think I don't think it's going to make a difference. I think it's going to be one of those treatments that if NICE get hold of it, they'll say the benefit doesn't outweigh the risk, and the benefit is very small.
Yep. Yeah. Sometimes what we see what looks like PED in young patients, often not at the macula. What would be the cause of this? What's the possible cause of this?
It's PED not affecting the macula, quite common. We see that quite often. I mean, that's part of the CSR spectrum in a young patient. The first and only thing you can ask them is, do they take steroids? And any form of steroids. So I've had a patient develop a CSR just because he was putting steroid cream on his little girl's eczema every evening. And of course, he put it on his hand to put it onto her skin, and then he developed a CSR. Bless him. I mean, the thing with steroids, our advice would be to stop them if you can. I never say stop them, because if you're taking steroids for your asthma, it may be that that's the difference between you being alive and not being alive. So I always say, you know, I consult with the doctor who prescribed the steroids, so your GP or your chest physician, to ask if you, because they can sometimes give you steroid sparing medication. But PED is part of the CSR spectrum.
Thank you. What happens when you have patients who've had their cataracts, say, at one of the private facilities, but they don't want to go back there because they've had a negative experience?
Well, we would say it is their responsibility. I mean, my own feeling, I'm a surgeon, I operate on cataracts, and if I operate on someone, it is my responsibility to make if things don't always go right, none of us are perfect. And if you have a complication, it is your responsibility to make that right. And it is your responsibility to look after the patient, to explain to them, to be candid with the patient, and to hold their hand the whole way. And if you are honest with patients, most people are very understanding and forgiving and listen and you know, want to be looked after by you. If you ignore them and don't treat them, then they don't like it. So the most important thing is that we all of us, everybody involved in eye care, treat the patients as we would want to be treated. And I think patients should go back to their referring hospital. Otherwise, they think they've been that you know they have no complications because we're dealing with them all. So we would prefer them to go back to the independent treatment centre to be treated.
Yeah, yeah. So I guess it's a case of communication with the patient
Mm.
at that point and just explain to
Absolutely.
them
And
why
also
it's
communication with the independent treatment centre. You know, I have on occasion rung them and said, look, you know, you have a patient, they're coming straight to you. They have query on endophthalmitis. This is your, your responsibility. They're on their way.
Yeah. Right. Somebody's asked for the email for DRS. I'll put it in the chat when I can next.
That'd be great. That'd be great, because they're very helpful. They will help you.
Referring to DRS, is that always via the GP, or is there a direct referral? You can
don't refer via the GP. Refer directly to them. Bhavina's got the email. They are responsive. Sam Mann is the consultant at St Thomas's who heads up DESP. We've talked to her about it. Denise McLaughlin is one of her right-hand women, and she will respond. They're very quick to respond.
Yeah, brilliant. Penultimate question. Thoughts on the photobiomodulation for dry AMD?
It's all a bit new. We don't know. We don't know yet. Thoughts are, let's just wait and see. Biomodulation it will be something that will work for some people and not for others.
Yeah, we don't have really enough evidence for who the right criteria of patients are for that. One of the things about pigmented lesions, obviously we have the NICE guidance, we also have the Royal College guidance, and we have the College of Optometry's guidance that talk about moles and when to be referring. There is a question mark about the size of the nevi as part of the moles and where it should be monitored. Now, obviously, if it's grade 2 below, it's monitored in community. If it's above that, then there is this caveat between urgent referral and being monitored by an ophthalmologist. So those pigmented lesions, what do we do with that? Because at the moment,
I would still
have a monitoring program under MEX.
I would still
get that contracted.
Yeah, the big ones, I would still prefer them to come via the emergency pathways, because I'd rather, we've all seen some great big ones, 8 disc diameter, because we will get an OCT through those just to make sure there's no subretinal fluid. If necessary, we'll do an ultrasound through them. We just need to rule out that they're a melanoma. We don't want anyone, you or me or anyone else, sitting on a melanoma. And trust me, I've seen someone do it. I've seen, and I'll just paint this. I won't say who it was, but an optometry practice sent in a patient saying this is a pigmented lesion in a young man. And they sent in the OCT from a year ago with subretinal fluid over the pigmented lesion, and the pigmented lesion getting bigger with subretinal fluid. And my registrar very nearly had a stroke. So that patient went very rapidly to more fields, but that it just can't happen. So I'd rather they came via our emergency pathway. We will look at them. If they're safe and small, we'll discharge them. If they're suspicious but not melanomas, we'll monitor them. And if there is anything suspicious, I mean, we had one recently referred in. It was a big pigmented lesion in a patient quite in the periphery, scalloped edge, no fluid over it, but the patient has a family history of melanoma. That patient is never going to be happy unless they've been seen by an oncologist, because I wouldn't be. So why should they? So we've referred them to more fields to have a look at it. And it's a big lesion. And although there's no subretinal fluid, he has a family history of melanoma.
Yeah, brilliant. That's all the questions in the chat. Does anyone else want to ask any questions before we finish? Oh, question mark. A question just come up. What is the emergency pathway for pigmented lesions? I'd like clarification.
Then you send it to RAU or CRESS or St Thomas's Casualty, depending on where your patient lives.
Yeah. Okay.
I was just going to make one comment actually around about what Emma was saying about when there's a complication post-surgery in a non-standard NHS hospital, in a private out something. The other thing is that we don't know what happened, I would just say, as a surgery. So it's much better the management is much better if you know what the complication was. And quite often you don't actually know what happened, you don't know what was given, you know, so there's a real benefit to the patient going back to the person that operated on them, okay? Even if that person just has to say, look, this is completely beyond me, I can't manage the complication, but at least I can tell you what happened. And we live in hope that they'll actually be honest about what happened during the surgery, because that really helps us to know what to do.
I know, I completely agree with it, Dana. I mean, we've had 1 or 2 patients with the wrong intraocular lens put in the independent treatment centre. It happens, you know, it happens. But we've had terrible problems getting them to release the biometry results. Now we can't plan to put things right unless we know, as Adana said, what they did first off. If we know what they did, then we'll be able to, you know, make some calculations and try and give the patient the best outcome. I saw the query. RAU is Queen Mary's Sidcup Emergency Service, a rapid access unit. So you email, everything is email. Don't send the patient, just email it. We'll look at them. We look at them constantly. And CRESS is the Denmark Hill, the main King's site independent casualty, and then obviously there's GSTT eye casualty.
Perfect. Okay, I'm going to draw this teaching session to a close, and I'm just going to stop recording.